changes, screening, risk-reducing surgery, and chemo prevention. And then we will have a short session on our breast cancer family registry, leaving time for questions and answers at the end of the webinar. Please feel free to ask questions throughout the webinar using the chat function, using the Q&A function at the bottom of your screen. We will answer those questions at the end of the webinar. Okay, I will turn it over to you, Dr. Trivedi.
Thank you, Christina, for the introduction. I'm one of the breast oncologists here at Columbia. So breast cancer is a common diagnosis among women. About 1 in 8 women will develop breast cancer over the course of their lifetime. In 2020, there will be approximately 276,000 new breast cancer diagnoses in the United States. That will be the #1 cancer diagnosis among women in the United States. While the majority of breast cancers are sporadic, meaning they occur without one clear cause, about 5 to 10%, it sounds like the audio is poor. Can you hear me better now? Okay, try again. About 5 to 10% of breast cancers are hereditary, meaning that they can be attributable to a specific abnormality in a gene. 15 to 20% of breast cancers are familial, and that means that there's some sort of component or family history that can contribute to the cause of breast cancer. There are many different breast cancer risk factors that some are environmental, some are family history related, some are related to reproductive factors. This slide shows several of the breast cancer risk factors and what their relative risk is to increasing breast cancer. So some of the environmental factors include alcohol serving, having outside chest wall irradiation. Sometimes that's done for treatment of other cancers. There are also several reproductive factors, such as having hormone replacement therapy use, early onset of menstrual cycles and late menopause, not having given birth to children, or having an age at first birth greater than age 30. Family history is also a big risk factor for developing breast cancer, in particular first and second degree relatives. Having increased breast cancer, increased breast density, or a history of an atypical breast biopsy are also risk factors. Having a genetic mutation, the most common genetic mutation causing breast cancer is having a BRCA1 or 2 mutation, and that is an almost 10-fold increase in developing breast cancer in the future. I alluded to the fact that having an abnormal breast biopsy can be a sign of an increased risk of developing breast cancer. So these are breast biopsies that show some sort of atypia. There are several different types of atypical breast biopsies, something called ADH or atypical ductal hyperplasia, ALH, which is atypical lobular hyperplasia, something called LCIS or lobular carcinoma in situ. All of these are benign breast lesions, but they do portend an increased risk for developing breast cancer in the future. This is a 4 to 10-fold increased risk of developing breast cancer later on. So what qualifies as being high risk for breast cancer? So the definition of being high risk for breast cancer is having a 5-year breast cancer risk greater than 1.67%, or a lifetime breast cancer risk greater than 20%. There are many different ways that we can estimate this risk. There are several different risk prediction models. Having a genetic susceptibility can also estimate one's risk of developing breast cancer. And again, having atypical breast lesions, as I described earlier. These are two of the most commonly used breast cancer risk assessment models, although there are many other ones, and I think we'll hear about some of those in the next talk. The most common one that's used is the GALE model, or the Breast Cancer Risk Assessment Tool, which you can find online. And another commonly used one is the IBIS, or Tyrer-Cuzick model. I put the factors that go into these risk assessment models on this slide, and you can see that there are many similarities between them, and they take into account several of the risk factors that I already described, including age, age at first period, age at the first time of birth, having a family history of cancer, having breast biopsies in the past, as well as those that show atypia. And then the GALE model also takes into account race and ethnicity. The IBIS model takes into account several other factors, including height and weight, a more extended family history, use of hormone replacement, having prior genetic testing, breast density, as well as having Ashkenazi Jewish descent. There also can be an increased risk due to hereditary breast cancer syndromes, and there are several genes that are associated with an increased risk in breast cancer. The BRCA1 and BRCA2 genes are the most commonly associated genes with hereditary breast cancer syndrome and are associated with a 60 to 80% lifetime risk of developing breast cancer. It is also, these genes, pathogenic mutations in these genes are also associated with several other cancers, including ovarian cancer, which is a 10 to 40% lifetime risk, pancreas cancer, melanoma, and prostate cancer in men. There are several other genes that have been identified to have an association with increased risk of breast cancer. High-risk genes are those that are associated with a 4-fold or greater increased risk of breast cancer, and this includes genes such as TP53, P10, STK11, CDH1, and PALB2. There are also moderate risk genes, and these are associated with a 2 to 4-fold increase of risk of breast cancer. These are genes such as NF1, CHEK2, ATM, and the NBN gene. So how do we identify who may be a carrier of breast cancer susceptibility genes? There are guidelines that have been issued by several organizations. Two of those are the National Comprehensive Cancer Network, or NCCN, and then the United States Preventive Services Task Force, or USPSTF. They issue guidelines to advise individuals as well as healthcare providers as to who should be tested for genetic cancer genes. There are also some groups that have advised population-based screening in certain groups. So this means regardless of other risk factors, some populations may be eligible to get genetic testing done for breast cancer susceptibility genes. And this includes breast cancer patients, as well as patients of Ashkenazi Jewish descent. And the reason you've seen now several times Ashkenazi Jewish descent come up in this risk, hereditary risk of breast cancer is that the BRCA1 and BRCA2 genes are found at a higher prevalence among those of Ashkenazi Jewish descent. While the prevalence of the BRCA1 and 2 genes in the general population is 1 in 400, among those of Ashkenazi Jewish descent, the prevalence is about 1 in 40. So what other factors may be associated with an increased risk of carrying a potentially harmful BRCA1 or 2 mutation? This includes having a personal or family history of an early onset diagnosis of breast cancer, that means under the age of 50, having a personal or family history of bilateral breast cancer or cancer in both breasts, having a personal or family history of both breast and ovarian cancer in one individual, having any male family member with a history of breast cancer, multiple cases of breast cancer in the family, or having one or more breast family members who have 2 primary types of BRCA-related cancers. And again, those of Ashkenazi Jewish ancestry may also be associated with an increased risk of carrying a BRCA1 or 2 mutation. So now that we've talked about what is high risk and what are some of the risk factors for breast cancer, the big question or important question is how can we manage this breast cancer risk? And there are several different strategies that we can use. We can have lifestyle changes, there can be screening, increased or intensive screening among high-risk women. Risk-reducing surgeries are an option for several high-risk individuals. And then also this idea of chemo prevention, or taking a medication to reduce the risk of developing breast cancer. So lifestyle changes for reducing breast cancer. These are not only important for reducing the risk of developing breast cancer, but also maintaining a healthy lifestyle, reducing cardiovascular disease risk, as well as other types of cancer risks. So these guidelines are established by the American Cancer Society. The recommendations are to limit alcohol consumption, ideally no alcohol consumption, but if you're going to drink alcohol, no more than 1 drink per day for women and 2 drinks per day for men. Exercise is also very important. 150 to 300 minutes of moderate intensity exercise, or 75 to 150 minutes of vigorous exercise per week. That's about 30 minutes a day, 5 days a week. Maintaining a healthy body weight is also really important, and then consuming a healthy diet. So this includes eating a variety of fruits and vegetables to get the important nutrients, eating whole grains, and minimizing red and processed meats, minimizing sugar-sweetened beverages, and also minimizing highly processed foods. Intensive breast cancer screening is also important among those that are at high risk for developing breast cancer. With screening, the goal is early detection, with the hope that if a breast cancer is caught at an early stage, it may minimize the need for chemotherapy or extensive surgeries. There are several different imaging modalities for breast cancer screening. There's the mammogram and the breast MRI. And among mammogram, there's also a 2D mammogram and then tomosynthesis or 3D mammogram. It's also important to have a clinical breast exam with your healthcare provider every 6 to 12 months. So when should someone start screening for breast cancer? So it's important to discuss all of your risk factors with your healthcare provider, but in general, breast cancer screening should begin about 10 years prior to the youngest diagnosis of breast cancer in your family. And so this means a mammogram at least by age 40, but not sooner than age 30, and a breast MRI by age 25, not prior to age 25, but at least by age 40. In those who are at high risk because of their prior chest wall irradiation, breast cancer screening should begin 8 years after completion of the chest wall irradiation, again with the same caveats as above. There are additional recommendations on when screening should start based on genetic factors. So there are certain genetic mutations, again, because of the risk that they portend for breast cancer, in which a screening MRI is important as part of breast cancer screening. And so the genes, I won't read them all, but they're listed in that table on the side. And it also lists the age at which MRI screening should begin. The important thing to note about breast MRIs is that while they are very sensitive, they are they're not necessarily specific. So one risk of doing intensive screening with breast MRIs is that there is a high false positive rate. Of course, the goal for women that are high risk is to catch something at an early stage, and the combination of MRI and mammogram has been shown to be more sensitive for early detection. And so in the case of high-risk women, we believe that the benefits of this intensive screening outweigh those risks. Again, for some women, the option of a risk-reducing surgery may be important for reducing the risk of breast cancer. And this is a reserved for women that are at an exceptionally high lifetime risk of developing breast cancer. And so there are certain genetic mutations where risk-reducing mastectomy, which is removal of all of the breast tissue, is an option. And this is in BRCA1 and 2 mutation carriers, P10 mutation carriers, TP53, and PALB2 mutation carriers. For BRCA1 and 2 mutation carriers, because of the increased risk of developing ovarian cancer, there's also a recommendation to have a risk-reducing salpingo-oophorectomy, which is the removal of the fallopian tubes and ovaries. And this is recommended for BRCA1 and 2 mutation carriers between the ages of 35 and 40 or upon completion of childbearing. And this has been shown to not only reduce the risk of developing ovarian cancer, but it also can reduce the risk of developing breast cancer by 37 to 74%, depending on whether you are a BRCA1 or BRCA2 mutation carrier. So it's an important consideration, not only for ovarian cancer risk, but also for breast cancer risk. And finally, I'm going to talk now about chemo prevention. So chemo prevention, again, is the use of anti-estrogen therapy to reduce the risk of breast cancer in the future. This is an oral medication that is taken for 5 years, and it's the same treatment, same medication that we give to treat hormone-sensitive breast cancers. While there's been extensive research or trials looking at the use of these medications in those who meet high-risk criteria, meaning a 5-year risk greater than 1.67% or a lifetime risk greater than 20%. There are limited data on its use in those with genetic predisposition syndromes, again, such as BRCA1, BRCA2, TP53. And there's also limited data in younger women, women under the age of 35. There are several options for breast cancer chemo prevention agents. For premenopausal women, so women that are still having menstrual cycles, there's only one option, and that option is tamoxifen, which is within a class of drugs called SERMs, a selective estrogen receptor modulator. There was a large study that investigated the use of tamoxifen, so every day for 5 years, and it was compared to women who did not take tamoxifen for chemo prevention, and there was a greater than 40% risk reduction in breast cancer in those who took tamoxifen. As with any medication, unfortunately, there are side effects, although in general, the side effects are fairly tolerable. Because all of these agents are anti-estrogen, the most common side effect that we see with any of these agents are menopausal symptoms, which include things like hot flashes, vaginal dryness, vaginal discharge. With tamoxifen in particular, there are some rare but serious side effects. And this includes blood clots, where there's a 1 in 1,000 risk of developing blood clots, which is about the same as oral contraceptive pills. There's also a slightly increased risk of developing endometrial cancer, about 2 in 1,000. And there's also a slightly increased risk of developing cataracts. The other agents, including raloxifene, anastrozole, and exemestane, are only able to be used in women who are postmenopausal, who have not had, meaning women who have not had a period in 2 years or greater. Raloxifene is a similar drug to tamoxifen, is a selective estrogen receptor modulator, while anastrozole and exemestane are another class of drugs. They are in the class of drugs called aromatase inhibitors. And all of these studies looked at large groups of women who were considered high risk and found significant breast cancer risk reduction, anywhere from 45 to 65% risk reduction. Unique to the aromatase inhibitors with respect to side effects are that these medications can sometimes cause an increase in joint pains, and there's also the risk of loss of bone density. So while women are taking these medications, we do watch their bone density closely. So with that, I will wrap up my part of the talk. Again, just in conclusion, that there are many factors that affect breast cancer risk, including genetic, lifestyle, and reproductive factors. However, we have effective risk management strategies that can reduce the risk of developing breast cancer in high-risk women, and these include lifestyle changes, screening, risk-reducing surgery, as well as chemo prevention.
Thank you, Dr. Trivedi. I will now turn it over to Dr. Mary Beth Terry, who will lead us into a discussion about the Breast Cancer Family Registry. Please do remember to send your questions in via the Q&A box. We will answer those at the end of the presentation. Thank you so much. Dr. Terry, please go ahead.
Wonderful. Can you hear me okay?
Yes, we can hear you.
Wonderful. And thank you so much to Dr. Trivedi for giving such a comprehensive overview about breast cancer management risk factors and the presentation. So I'm going to very briefly give an overview of our research program that we've been doing over the past 25 years in order to better understand what are the drivers and also what can reduce risk in women at very high risk of breast cancer. In particular, I'm going to speak very briefly again about the Breast Cancer Family Registry and the importance of having research cohorts like the Breast Cancer Family Registry, particularly in order to understand what are the drivers in higher risk women. So here, if you could just, I'm sorry, press the highlight there. Great. So what I'm highlighting here in this graph is a distribution of cancer risk. So you may have heard the 1 in 8 figure. The 1 in 8 figure means that approximately 12% is the risk of all women for getting breast cancer within their lifetime. And usually that's calculated until age 80. So what I highlight here in green is really all the individuals that are under that 12% risk. Next. And what I highlight here in pink are all the individuals that are above a threshold of 20% lifetime risk or higher. As Dr. Trivedi said, there's models to indicate if you're at higher risk. Usually women who have a 20% or higher risk are encouraged to have more frequent screening, are encouraged to think about chemo prevention. And so what you can see here is this breast cancer family registry cohort that we've been following for over 25 years, and we have multiple generations of women and men within these families, that there really is a spectrum of absolute breast cancer risks. So on the x-axis is showing the absolute lifetime risk predicted by the family history. And on the y-axis is showing how many women are in our cohort. So this is a cohort right now of over 18,000 women, and we follow them prospectively to understand who gets cancer and who does not get cancer within families. The main take-home message here is even if you have a family history of breast cancer, so all of the women that are represented here on this graph, all 18,000 have a family history of breast cancer, you can see there's a wide range in terms of their absolute risk. And so it's important always to think about that just because you have a family history, you may be actually at lower risk than the average woman, but you may be at higher risk. And so in order to understand that risk, as Dr. Trivedi argued, you need to understand whether you have specific mutations and understand also the extent of your family history. Next slide. So what we've been doing, again, is to look in this high risk cohort to both understand what are drivers of cancer risk in addition to genes. So specifically, how can we reduce risk in individuals who we know are at higher risk? So this is a picture of the cumulative occurrence of breast cancer throughout life. So as many of you know, there is a much higher risk the older you get. That's true for all cancers. As you can see, the risk increases very dramatically after menopause. Here we highlight 3 groups of women from our cohort, those that are at higher risk, so those that will have known mutations in breast cancer susceptibility genes, as Dr. Trivedi just outlined the key genes. Moderate, which again would be some breast cancer susceptibility genes, but of lower penetrance. Penetrance means the probability of getting breast cancer within your life. So it's important to know that just like other cancers, the genes that are known to cause breast cancer, none of them are 100% penetrant. So what that means is even if you have a gene mutation, there's not 100% probability that you will get cancer. So no gene for cancer is 100% penetrant. That differs from other genetic diseases, such as Huntington's disease, where if you have the gene for Huntington, you will get Huntington's disease. It's just a question of at what age. So it is really important to know that even if you're at the higher risk of that whole distribution, that there are ways to modify your risk. So here's an example just in terms of thinking about healthy weight. And again, healthy weight becomes much more important in postmenopausal women. And you can see that for women who have a higher absolute risk, so based on their family history, so the top cluster, that if they were to modify their body mass index, or a measure of body size, if you're over 30, that's defined as obesity based on the Centers for Disease Control in the US. So that would be the yellow. If you're above 25, which is represented in blue, that would be overweight. And then showing a lower and a higher bar than that. So you can see that if you're at lower risk, so if you're at what we call population risk, which is the 1 in 8 figure, then you would be at the very lower cluster of colors. So yes, you still can modify your risk, but the absolute change for doing that is lower than someone who has higher risk based on their genes. So the message here is that all women can modify their risk of breast cancer, but there will be a larger impact at those who have a higher risk. So here are some findings, again, from the Breast Cancer Family Registry cohort. And it's important to say that we are so grateful for all of the women and men who have participated all over the years, because the Breast Cancer Family Registry cohort is only one of 2 cohorts in the entire world that's a family-based cohort. And we really do believe that these family-based cohorts are very important for understanding the drivers of how to reduce risk based on your genes. And most breast cancer cohorts that you may hear about in the news have been started generally after age 40, and generally are focused much more on understanding risk in average risk women, not in women who are moderate or higher risk. Here's a finding published recently by our group looking at the use of regular use of aspirin, which is a non-steroidal anti-inflammatory. And what you can see here on the left side is that all groups of women do have a lower risk if they're using regular use of aspirin. And the vertical bar that's dashed there is the bar of no difference between the aspirin users and the non-aspirin users. And anything to the left would mean that those women who use regular use of aspirin have a lower risk than those that don't. Again, it's statistically significant for women without BRCA1 or BRCA2 mutations, but the effect size or the direction of the association is the same in all groups. And you can see on the right-hand side where we look specifically based on their absolute risk as predicted by the models that Dr. Trivedi had explained, we see also all of these groups benefit from the regular use of aspirin. So it's all to the left of that dash bar. These are observational studies, so they are not randomized clinical trials. So I emphasize that because it is important. We were able to look at a lot of other factors that vary between women who use aspirin and women who don't, but it is also important to emphasize that because aspirin can have some detrimental effects, that it's always important to talk to your doctor about regular use of aspirin or any non-steroidal anti-inflammatory. And likewise, in a very similar orientation of the previous slide, we did see a very consistent association for physical activity in BRCA1 carriers, BRCA2 carriers, and again, based on their absolute predicted risk. We've gone on now, it hasn't been published, but recently have finished analyses looking at adolescent physical activity. So again, these are associations that support a potential way to reduce risk in women, but again, differ from these average risk cohorts in that it's showing that it's also important for women at higher risk. Next. And just like Dr. Trivedi said, it's important to understand how to identify women who would be at higher risk. And so we've done some of this using clinical risk models. And she spoke already about the IBIS or Tyrer-Cuzick model, which is represented on the left in blue. We also use other models that are used in the clinic, particularly for women who have a strong family history. Those include the Bodicea in red on the left, BRCA Pro in pink, and then the Gale model, which Dr. Trivedi already mentioned. On the right, these different graphs show you that even though the models are well calibrated on average, that they still tend to underpredict in women at lower risk. So the x-axis in each of these 4 quadrants is showing the predicted absolute risk. And in this case, it was a 10-year risk. And then what's shown in blue in these 4 boxes is what we actually observed after an average of 10 years. So to the extent that the red line and the blue line don't match up, that means that the models that are used in the clinic still are under predicting women at lower risk. And they're actually, interestingly enough, over predicting in some of the higher quadrants. So that has implications then in terms of how to think about these models and when they get used. And we and others are working on model extensions to improve how these models work in prediction. Finally, one of the recent findings that we have, and again, we wouldn't be able to do this without the generous contribution of individuals who decide to participate in research studies, and this is really the only way we're able to validate some of these clinical risk tools in these large cohorts, is that we looked specifically at what happens for women who test negative when they have a family history. So there's 3 rows here. On the very top is women who test negative. So the woman herself tests negative for BRCA1 or 2, but she has more than 1 or more relative who tested positive for BRCA1 and 2. And the middle bar there is showing women who test negative, and her relatives, at least one, is known to test negative. And then finally, the bottom bar is showing women who test negative, and we don't know what happened to their relatives if they tested positive or negative. So on the left-hand side is what we call the calibration, which means how accurately does the model predict your risk. So you want all of the estimates on the left-hand side to be very close to the vertical bar of 1. And what you can see first in the top row is that there tends to be a skew towards the right, which means that they actually, the expected is more than the observed because the ratio is over 1. So they actually, women in this that meet this criteria, the models actually overpredicted. In the middle row, they underpredicted, and in the bottom row, they underpredicted because they were to the left, meaning that the observed was greater than what the model said. So I'll just emphasize for the middle group, what that means is that women who test negative and their relatives also tested negative, the models actually wound up where the expected was less than the observed. So the models underpredicted based on that negative result. So that means too, we have a long way to go with how these models work. On the right-hand side is another metric we use for model-based performance. And you can see there we have a long way to go. So these models are calibrated well on average, but for particular subgroups, they still need a lot of work. And in particular, the group that needs work in our mind right now is what happens when you test negative. Because the way the models are working is that they're under predicting for a large group of women in that middle section. So again, if you'd like to, or you're interested in knowing more about our research project, feel free to email, or if you have questions or anything else about what I talked about, feel free to email at any time. That is our specific website for this study. Again, feel free to reach out at any time. And then finally, before we do the question and answer, we wanted to thank you again for attending the seminar, which has been sponsored by the Herbert Irving Comprehensive Cancer Center. And if you haven't already, and you would like to receive notification of free online educational events about breast cancer as well as other cancers, at the Community Outreach and Engagement Office, we have many activities, including last week we did a yoga event. Next month we're doing lung cancer events and colorectal events. So please do join our mailing list. We have it right there in the chat box. And that way you'll be automatically informed about upcoming seminars and webinars.
Thank you very much, Dr. Terry, and thank you, Dr. Trivedi. Now we will start our Q&A portion of the webinar. We did have a question come in throughout or during the presentation, but as I read this to the panelists, please, if you have a question, feel free to type it into the Q&A box, which should show up at the bottom of your screen. So this question came in that says, my mother was diagnosed with breast cancer in her mid to late 30s and had an aggressive course. She's found to have a variant of uncertain significance in the PALB2 gene. How should I proceed with my breast cancer screening? Do variants of uncertain significance get reclassified? Dr. Trivedi, would you like to start off with that question?
Sure. So thanks, Christina. This is a great question. I didn't talk about what it means to have a variant of uncertain significance. And so, what that essentially is it's in all genes, you have different changes that can be seen in genes or different variants. Some variants are known to be pathogenic, meaning that they have the potential to increase your risk of developing breast cancer. And there are other variants that are known to be benign, meaning they should not be associated with an increased cancer risk. A variant of uncertain significance is a variant that's been detected, but we're not sure. It hasn't been detected frequently enough to know whether it has pathogenic or potential to cause harm. So variants of uncertain significance ultimately get reclassified. And there are, when one is detected, it's important to follow up with the genetic counselor or the healthcare provider that detected it, because often the companies that are running the genetic testing will send updates once the variant has been reclassified and after more data has been obtained. In particular, for the person asking this question, I think that since it's not clear whether this variant contributed to your mother's risk of developing breast cancer, I think it's still important, given that family history, that one should undergo high-risk screening about 10 years prior to the onset of cancer in the earliest family members. So if it was in the mid to late 30s, then starting in the mid to late 20s with breast cancer screening. And again, it's important to discuss all the details with your healthcare provider, but in general, we start at, if it's under the age of 30, that breast cancer screening is going to start. We start with a breast MRI, and then it's after age 30 that we add in the mammogram. For high-risk women, I didn't touch on this in the talk, but we often try and also stagger the imaging every 6 months, so that there's some breast imaging that's been being done every 6 months. But still, it's only once a year MRI, once a year mammogram over the age of 30.
Thank you, Dr. Trivedi. Okay, we had another question come through the Q&A. I think it's a great one. Probably a lot of people on the call and in general have this question or a similar one. I have a family history, mother, aunt, and first cousin. My doctor is encouraging me to have a BRCA test, a BRCA test. However, my concern is, then what? Do I really want to know my risk? And I think, either panelist, please go ahead and feel free to jump in to answer this question.
It's another really good question. I think it's always important to think what you would do with the information. I would definitely recommend speaking with someone who's knowledgeable about genetic testing, whether that's a healthcare provider with that expertise or a genetics counselor, because it's important to hear, what would you gain and what would you do with that information. It is powerful information. It can help, knowing that you have a mutation can help reduce implement early screening or other risk-reducing strategies. But at the same time, there are risks. Can cause psychological distress or anxiety, knowing that you have this mutation. It can cause family difficulty. So I do think I would encourage you to meet with a genetics counselor to kind of discuss what are the risks and benefits and what this information would mean to you and how it would change what you do for your own management. And then the other thing I'll just add is that when it comes to genetic testing, while if you meet the criteria, it's important to get tested, the best person to test would be an affected family member, someone who has a diagnosis of breast cancer, because we'd be more likely to catch pathogenic mutation in the person who's been affected. Dr. Terry, I don't know if you have anything to add to that.
No, I think that's a very complete answer. And I do encourage you to talk to a genetic counselor to decide, because, everyone is different and needs to weigh the pros and cons. I would just put a extra push though for earlier screening, which is always beneficial. So, so knowing your risk is important for earlier screening.
Great, thanks to you both. We had another question come through in the Q&A about the different models for breast cancer risk. And if I characterize this question incorrectly, would the person who answered or who asked this please just correct me via chat or the Q&A box. So the question is, how many pieces of the different models does a person need to fit in that particular model? And I think maybe the question is asking about the use of the different models and, how does that work in terms of personal risk? So I don't know, Dr. Terry, do you maybe want to talk about the different breast cancer risk models and what that means for a person in terms of determining risk?
Sure. So it's a great question. And I sometimes, when I teach, use examples from some of our families that we followed, because depending on the model you select, you can sometimes get differences in lifetime risk that are as different as 30 points, believe it or not. So you could have one model suggest a lifetime risk of, for example, 12%, and the other model could be above 40%. So that usually would happen if someone is using a model that was developed primarily for average risk women, like the Gale model, and they have an extensive family history of both breast and ovarian cancer, in which case some of the pedigree models would put a risk at higher. However, it can work in the opposite direction. So you could use, one of the pedigree models and actually have a lower risk than the Gale model, even with a family history, because the way the Gale model works is it counts up the number of first degree relatives, like your mother or your sister or your daughter. And if your mother or your sister had breast cancer much later in life, you're actually at a lower risk than if she had had it, in her 30s or 40s. And so the Gale model doesn't factor that in. It just counts relatives. And so if you were to use the Gale model, then you could actually be at a higher risk if you had a sister than if you had who was diagnosed later than if you had a sister who was diagnosed younger. So I use it in class because I think, you know, if we had tests that told students under one scenario they would pass and under another they would fail, right? If we say 30 points, which is what we usually use to say whether someone has 100 or a 70, then, you know, that would be so unacceptable to students. But the fact that right now we still have that kind of disagreement between the models is really, I think, not adequate. So that's why a lot of people, including we have been and other groups have been trying to improve these models and also have a clearer understanding of under what scenario a model would be appropriate or not. So the biggest drivers of these models are really three things. One, the family history. Two, your mammographic density. So breast density itself, as Dr. Trivedi had explained, is a very strong risk factor for breast cancer. And the third big driver is whether or not you've had prior benign breast disease. So again, there's a lot of room for improvement, and that's true for the other cancers as well. Cancers like prostate and cancers like colon also have the models need to be improved. So that's you know, a big push now as we're learning more about genes and what interacts with genes and lifestyle factors that modify these associations.
Great. And there was a follow-up to that question that says, what would be the amount of ASA that an at-risk patient would take? I don't know if we need to ask for some clarifications on that question, and maybe we can come back to that. Okay, another quick question on the models, since we're on that topic, came through. Which racial ethnic groups have these models been validated for?
Do you want me to handle that? I'm sorry, was the previous question for me or for Dr. Trivedi?
It's for either panelist. I'm not sure what the question, it says, what would be the amount of ASA that an at-risk patient would take?
Yeah, I think they were asking Dr. Terry, with the chart that you showed with the reduction with aspirin use, what was the, do you know what the dose of the aspirin was for that?
Yeah, so that's a great question. Sorry. So, and again, I want to emphasize that this was not a clinical trial. So what we asked was about regular use. So regular use in this setting was using aspirin several times a week. So 3 to 5 times was really defined as regular use. I will mention that not just for breast cancer, but for other cancers, including colorectal cancer, there's a large body of data that supports regular use of a aspirin or nonsteroidal anti-inflammatory does reduce risk of many cancers. However, regular use of aspirin is not for everybody. So it should be discussed with your doctor because there are side effects from regular use of aspirin. So that's something to discuss with your doctor. And you know, in addition to nonsteroidal anti-inflammatories, there's other, for breast cancer specifically, there's other chemo preventive agents that may be more effective with fewer side effects. Again, something to talk to your doctor about. With respect to the second question about have these models been validated in other race and ethnic subgroups, it's an excellent question. This has been a challenge for cancer cohorts in particular because of the long time between for cancer to be developed. So many models related to cardiovascular disease and more common outcomes have advanced much quicker because you only have to follow people just a few years in many cohorts. In most cancer cohorts, to develop the models and validate the models, it does take many years to follow them. Some of the models are good and have been validated in very diverse cohorts. In particular, the Gale model has. We've looked at these models within our cohort, which has about 20% of non-white participants. And so it has been done. It needs to be done more. And again, across the board in all research, this really needs to be a really important area, in particular for young women, because again, for young women, the models themselves have mostly been developed in older women. So again, the more we can do to understand risk prior to when most people would have regular screening mammograms, the better we are at identifying people who could truly benefit from earlier screening.
Great. So a couple more questions have come through on the Q&A specific to, personal risk factors. So one question is, my daughter was recently found to have a BRCA1 mutation. If we contact the high risk evaluation phone contact, what could we expect? And I'll just put that up there for everyone to take a look at. And maybe Dr. Trivedi, you can take this question.
Sure. So, by calling that number, that is our new patient team, and they will get you in touch with one of the breast oncology team members. I'll also just point out, since this is specific for a BRCA1 mutation, we do have a hereditary breast and ovarian cancer program here at Columbia, and we have another phone number for that, which is 646-NYP-HBOC. So hopefully it's hereditary breast and ovarian cancer. So you can also call that number. Either number will get you through to a breast oncologist. And we have a multidisciplinary team here that helps manage all the cancer risks that comes along with carrying a BRCA1 mutation. And so with that, you would expect to meet with a breast oncologist like myself, a gynecologic oncologist to manage risk of ovarian cancer, as well as a GI oncologist, and even other referrals such as a dermatologist. And we all work together to try and make sure that we're managing the various different aspects of risk that are associated with the BRCA1 mutation. From my perspective as the breast oncologist, we would meet and we would do a breast exam, number one, and then talk about the different ways of screening, and depending on the age of the individual, we would talk about MRI plus or minus a mammogram if over the age of 30. So it can be very overwhelming all at first. Our goal is to try and coordinate the multidisciplinary care that these mutation carriers need in order to ensure that they're doing everything possible to reduce the risk of developing the cancer in the future.
Thank you. Another question that's come through is, I have a family history. My mother was diagnosed at 59, 2 aunts and 3 great aunts, 1 grandmother at 66. I'm 27. What should I do? All are BRCA1/2 negative. Dr. Trivedi, maybe
another good
that one.
Yeah, sure. Another good question. I think this person's a perfect candidate to come in for a high risk evaluation so that we can look at all the various risk factors and come up with a comprehensive plan to make sure that we're doing everything we can to reduce the risk of developing breast cancer in the future. 27 years old is very young, and so we want to make sure that we balance the risks and the benefits. Again, at the age of 27, taking chemo prevention has not been well studied. That usually waits until after the age of 35, but there may be room for interventions with regards to lifestyle changes and also screening if appropriate.
Great, thank you. We had another question come through in the chat. What if an aromatase inhibitor is only taken for 4 years? If stopped at 4, how much does risk increase? And I think this can be a question for either or both panelists to weigh in on.
Yeah, I can take a first stab at it. So also a good question, and something that comes up often. Taking the chemo prevention pills does come with side effects, and for some women it's difficult to tolerate the side effects, and they may not be able to complete the full 5 years of treatment. What that means as far as absolute numbers in risk reduction, how much that changes, it's not really clear. The studies looked at 5 years of taking the medication. So I can't give an absolute number of how much the risk reduction is if you take it for 4 years as opposed to 5. But we do think that there is a benefit that's attained by even taking it for a few years, even if you can't complete the full 5-year course. There is ongoing research trying to look at if we change the doses of some of these medications or if we change the duration, what does late last year that looked at low-dose tamoxifen for a shorter period of time, 3 years instead of 5 years. And in this study, they did see a reduction in the diagnosis of breast cancer, even with a lower dose of tamoxifen for a shorter duration. It was not compared head-to-head with that, full dose of 20 milligrams for 5 years, but it did still show that there were less side effects and that there did seem to be an impact on the diagnosis of breast cancer in women who took this chemo prevention.
Thank you very much. If there are any more questions, please go ahead and enter them quickly into the Q&A or the chat, because we are winding down from this webinar. I will let you all know that should you want a recording of this webinar, we're happy to send. And there will be a short survey once this webinar ends that will pop up on your screen. So please do fill that out for us. And as Dr. Terry mentioned, if you are interested in attending other events that we offer, virtual and maybe eventually in-person events, please do sign up for our mailing list. And you can also visit our website, cancer.columbia.edu. We have an events page at the bottom of the homepage where we list out events for our community members. Thank you again, and thank you to Drs. Trivedi and Dr. Terry. And that concludes our webinar today. Thank you.
Thank you.
Thanks, everyone.